we are opening up the conversation on fibroids today and women's health as well. I am Leah McIntosh, and it is my honor to be your host for this afternoon. And I'm going to just keep the conversation going, because if we are going to not tell secrets, we've got to get comfortable with each other. So as we begin today, I want to ask a question. What is it that brought you here today? And if you would describe that in one word, what would that be? So I want to invite you to share with the person next to you. Share with the person next to you, and then we'll ask you to share with the broader group. So you've got 30 seconds, lady, to share a word with your neighbor and tell them why you came here today. Ready, set, and go.
That is true.
Okay, ladies, let's come back together. So each one of you have a reason why you came today. So share your word or your reason why you came. Let's have at least one woman from each table share with us. So who'd like to start? Over here to my right. Information. And tell us your name. Regina, thank you.
My word was information too, but a person at my table said solution.
Information and solution. And tell us your name. Shelly, thank you.
My name is Robin, and it's hereditary in my family, so that's why I wanted to know.
Okay, thank you. Robin said it's hereditary in her family, so she's here to get information and solutions as well. Thank you. Anyone else from this table?
Well, I'm a nurse, so I just wanted to get more information so I can be able to talk to my patients about it.
Wonderful. Tell us your name.
Okay, RJ.
RJ, thank you.
I'm Andrea, and my sister recently had endometriosis, even though we knew she was bleeding for a long time. And so I surveyed the females on my mother's and father's side. Come to find out I had first cousins who have had the surgery and hysterectomies, aunts and all that, and I never knew until like 18 months ago. Now this year, the same sister just had a gallbladder removed, and I'm wondering, is it connected?
Okay, so Andrea and her family history has her here to get more information. Thank you, thank you.
Julia, frustrated with fibro.
Okay, thank you, Julia, for being here.
To educate and from experience.
And tell us your name.
My name is Norma.
Thank you. Education and experience. There's a common experience in this room. Either we've experienced something related to fibroids or women's health, or we know someone in our family, our friends, so we are here also on behalf of them. Thank you.
Juanita, and as the young lady here mentioned, treatment.
Thank you, Juanita. So treatment, how do we go forth? Absolutely. And our back table or to our left?
Oh, back table, we have awareness. This is my daughter, she said she was drugged, but no. So awareness and information, friendship.
Friendship, awareness, and information. Tell us your name.
Ari.
Ari, thank you. And to all the women who have gathered, and all the girls who are gathered, we are here standing together, getting information, greater awareness, treatment, solutions to go forth as healthy women. and I am so grateful. Again, I'm Leah McIntosh, and I am grateful to be a friend of Terri's. Our relationship goes back over 20 years, where her husband and my husband are best friends. And so we met along that journey and have had the opportunity to share holidays together and to be at church together and to pray together through surgeries. I remember the day we talked about the next step and what Terri was going through. And we stood together in prayer that the treatment plan would be successful. I'm so grateful for our doctors that are here today that I'll get a chance to introduce. Dr. Tracy and Dr. Laura, who are here, not only because they are experts in their fields as OBGYNs, but because they have a heart for women just like us. So with that, I have the pleasure of now introducing Terri Allen, our first speaker of this afternoon. So I want to invite you to open up your program before Terri speaks. As you can see the front. Go ahead and open that up because Terri's biography is printed. Now there is so much more about this woman that couldn't be printed on this biography, but I want you to know just a little about her. She is a nationally certified fitness instructor and personal training. But her heart really is for women and not just their fitness, although she is obviously fit and fabulous. Her heart is for the wellness, which is the total health of us as women. You have seen her on television, on the morning shows in Kansas City, and her influence spreads wide. She has organized this conversation, especially titled No More Secrets, because she knows what it's like to hold a secret and now pull back that veil and share with us so that we can be empowered. So with that, please give Terri a big round of applause as she shares with us this afternoon.
Thank you so much. I'm Terri Allen. Thank you for coming out. You being here means that you've decided to stop the secrets, the stigma, and the shame of fibroids. And I'm glad that you came because now you see there are other women like you that want information, want medical information, and an empowerment to move forward with your battle with fibroids, or just finding out more about it. So I wish I had a support group like this when I first started with my battle with fibroids. I remember in the exam room at Dr. Dome's office, you'll hear from Dr. Dome later, and I remember her walking in and with her, she slides in and she says, "Hey, you have some pretty massive fibroids." And I'm like, yeah, I had just heard about the fibroids just a few days earlier, and I had an ultrasound. So I still didn't know what was, going on. I've just been sent to the specialist after an ultrasound. So from there, she asked, so do you have kids? And I said, no, my husband and I have been trying for a few years, but no, nothing's happened yet. And she goes, so do you want kids? And then, her face kind of, got more serious. And so why was she asking me that question? We went from UTIs to fibroids to now she's asking, so did you want kids? So I got a little nervous at that point. And I said, well, yeah, and I said, well, what's going on? So at that point, she said, you need to have a hysterectomy. And my heart dropped. So I thought, she has the wrong chart. That's really what I thought. And I believe I even said out loud, you sure you're looking at my chart? And she's like, yeah, you didn't know you had these fibroids? I'm still, back. Well, wait a minute. You sure? You looking at Terri Allen? Because I'm fit. I'm a personal trainer. I teach kickboxing and Zumba, and I empower other women. So you got, Terri with an I. You sure you got that chart? So we went from there, and so from there, talking to other women, a friend of mine find out, getting out misinformation, my symptoms, or I remember a friend of mine, I'm telling her about my symptoms or my period. kind of early. Oh, everybody has that. Oh, okay. So the same girlfriend, she's in the fitness as well. So she tells me, you know, she's teaching kickboxing. If, you know, she kicks her leg up one time and blood splatters on the mirror. You know, when we're teaching and we have that mirror and blood splatters. So I'm like, what would you do? You know, because it's a class. And she's like, oh, girl, that's menopause. That's just be prepared. So I'm thinking, oh, that's okay. So I thought this was normal stuff. You know, I remember planning a trip to Las Vegas. Girlfriend and I is going to Las Vegas, planning a trip, and so I go to the doctor and I asked her to prescribe me some birth control just for this trip, because my period was going to come during this trip, and I didn't want to be bleeding during the trip. My periods are so bad that when I would change my tampon, I would bleed on the floor before I could get the other tampon switched. Thinking back now, I thought this was normal, y'all. I just thought this is what women turn 40, 41, that this is our life. And so I never knew. So when getting back to Dr. Dawn, her asking me these questions, what? I mean, really, I probably was the most shocked patient that Dr. Dawn had, because she was looking at me like, I don't understand. You know, like, how do you not understand? But I was really shocked. Everything she said after that was like this. She was talking, but I was done. I was gone someplace else, still like hysterectomy. So after a few tests, MRIs and CAT scans, finding the size and the dimensions and the locations of the fibroids, my husband and I, we went ahead and decided to go with the myomectomy. The myomectomy is the procedure, and the doctors can explain about it later, but that is the procedure where you remove the fibroids but still keep the uterus at a chance of still getting pregnant. So we go ahead, and I remember Dr. Dawn's nurse calling me the night before my myomectomy is scheduled, and she tells me, you know, so you have this many, and this one is this 5 centimeters, and you know, blah, blah, blah. Look, we think you have about 5. So I'm still in denial. I said, we really gotta do this tomorrow? It's scheduled. She called me about 4 o'clock in the afternoon. In the morning, it's supposed to be going. I said, we still have to do this? She said, yes. With your location and the many that you have, yeah, we have to go ahead and have surgery. So my husband and I prayed the night before, and we prepared for a myomectomy. So the next day after surgery, I remember waking up, and the first faces I see is my mom and my husband. And my mom tells me, you need to talk to Dr. Dawn. So I knew something. You know how you see your mom and you start crying? You know, you see your mom, you're like, oh, what? Well, I'm still here. So I can't be so bad. Okay. So I talked to Dr. Dawn, and she tells me that it's a 2-hour procedure, two hours or more. She was exhausted. It was more fibroids than they thought I had. She stopped counting at 20. She was only able to take out 16. She had to leave 4 because the damage to my uterus would have been so bad, and she knew that I didn't want to have a hysterectomy. So unfortunately, shortly after that, about a month or so, a couple of months, I ended up having to have the hysterectomy, going back to the beginning. It was sad for me, you know, that's unfortunate for me, but for most of you, that won't be your story. You know, circumstances are different. That's why I'm so glad that we're having this talk, so we can now talk about the symptoms, you know, that we all might have been walking around here with, thinking that this is normal, and talk about the treatments, and that's why I brought the professionals in, the experts, so we can get this out and no more secrets, y'all. We can start this movement. So thank you for listening to my story. That's why I wanted to share my story with you, to let you know that you're not alone, you know, that I've gone through it too, and most women probably will go through this as well. All right, so I'm going to turn it back over to Leah so we can listen to the experts.
Thank you, Terri. It takes a lot of courage to tell our stories. So thank you for opening up your heart, and hopefully this opens up the doorway for you also to tell your story and empower the women in your life. I now have the pleasure of introducing our first expert, Dr. Tracy Johnson. Tracy is an OBGYN practicing here in Kansas City. As I asked Tracy, or Dr. Johnson, if there was one thing you would want this group of women to know about you, she said 3 words that start with F. It's faith, family, and her field. Day after day, Dr. Johnson pours out her heart for women just like us. She's truly an expert who teaches and shares and empowers us and helps to heal women like us. So would you give Dr. Tracy Johnson a round of applause as she
I'm going to talk back here just because we have a little bit of a presentation. Can you hear me guys over there?
A little louder.
A little bit louder. So, as she stated, I'm one of the OBGYNs in the area. I work with Dr. Doan very intimately. I've actually seen Terri and other patients just like Terri. And I have a lot of slides. This is very educational and interactive. So, while we usually do talks and, different presentations, and we have people ask for questions at the end, it's very important that you understand what we're talking about today. That's the whole reason why we're here. I think every single table talked about education. So if you're okay with it, if you don't understand something, I really do want you to kind of raise your hand and put a pin in that right there, because that's kind of one of the reasons that I went into medicine, is kind of dispel a lot of the myths and make sure that people understand on a level that they can actually seek care and understand what's being talked about. So as she talked about, we're going to talk about fibroids. I always find it kind of squeamish when people say expert, because I don't know that we're ever experts, but we know a lot, so we'll try. So I was tasked with the opportunity of talking to you about what fibroids are, who gets them, and kind of how to diagnose. And then Dr. Doan's going to follow up and talk about all the different questions that you have about how to treat and things like that. Go ahead. So, oh no, go back. Let's see. If you just push the right arrow. Nope, let me try to help you. Nope. So who gets fibroids? First and foremost, what are we talking about? As an OBGYN, people come in and they don't say fibroid all the time. They call them all different kinds of things. Sometimes they say I have a muscle growth down here and my periods are bad. Sometimes they say I have those tumors and my mom had those tumors and my sister has those tumors, and sometimes they made it hard for pregnancy, and sometimes they made it hard for my periods. Some people call them fibromas in the Latin culture. The Spanish word is fibroma. People in medicine will sometimes call them myomas, leiomyomas, and then the big ones, I don't know who started this, but people always call them Big Bertha. And they say, I have a Big Bertha down there, and I need you to take it out. I don't know, I've heard that like 10, 15 times, just in the last 2 years, that people call them that. The big ones get that name, I don't know why. You can go ahead. Let's see if it'll go forward. Yeah. So what are they? They're tumors of the myometrium. That's the muscle part of the uterus, and I'll explain that when we get a little bit closer. And it's a Latin word. Leo meaning smooth, myo meaning muscle, and then oma is a name for a tumor. So it's a benign muscle growth of the muscle part of the uterus. Go ahead. So we think about the period. It's interesting that Terri talked about this, because she said she didn't really know that her period was abnormal. I would caution you, does anyone ever know what anyone else's period is like? No. So everybody always says, well, I thought that was normal. And it's funny, because in the office every single day people go, oh, that's abnormal? Or I say, how's your period? They say, oh, it's normal. You don't know what somebody else's period is like. You only know that your mom or your grandmother or your aunt told you that it's supposed to be 5-7 days. You're supposed to only need ibuprofen or Midol, and you usually don't soil through your clothes or your bed linens. As long as you don't have any of those things and you're not, coming home from work and laying down on the table or having to take a shower or you have to miss work, usually you think that's normal. But by and large, when we think about normal periods, we can kind of understand what abnormal is. So when you think about a period, and I know this is mundane, but just entertain me, the brain talks to the ovary and tells the ovary to make hormones. It tells it to make estrogen, and estrogen is fertilizer for the lining of the uterus or the endometrium. That grows, and after 2 weeks, if you ovulate and you don't get pregnant, it sheds, right? So I like to say that ovulation, where that egg comes out, it peaks around day 14. When the ovulation happens, that tells the gardener to go mow the lawn in the uterus. Does that make sense? And then it comes out. Does that make sense? I know, I like that. I use it all the time. If the brain talks to the ovary, tells the ovary to make those hormones, then the actual muscle part, right? So you see that inner pink area? That's the endometrium. That's what sheds. That's the gardener, the stuff that sheds every month. And then the lighter orange part, that's the muscle. It says myometrium. That's where the fibroids are, right? And then you have the outer part. That's called the serosa, or the outer lining. Okay, so that's normal. So you're supposed to, every month, you're supposed to shed that lining. The muscle part makes you cramp and makes it push out. Does that make sense? Okay, go forward. So then when we talk about fibroids, you can go forward again, Dr. Doan. They're muscle growths, and they can happen all over. So if we deal with the one that says pedunculated submucosal inside, it's that little one at the top. That one has endometrium around it, so that's going to bleed every time you hit it. If you, what did she say, do the splits, and then if you bleed on the mirror, that's the one that's going to bleed with any kind of activity. It's going to bleed with intercourse. It's going to bleed when you're exercising or running. Any little thing can make that bleed, because do you see how it's covered but with a little bit of that tissue that you shed every month? It's not really obeying any rules. It's sitting there doing whatever it wants. Then you have the one at the top that says pedunculated. If you, what did she say, do the splits, and then if you bleed on the mirror, that's the one that's going to bleed with any kind of activity. It's going to bleed with intercourse. It's going to bleed when you're exercising or running. Any little thing can make that bleed, because do you see how it's covered but with a little bit of that tissue that you shed every month? It's not really obeying any rules. It's sitting there doing whatever it wants. Then you have the one at the top that says pedunculated subserosal. That sucker hurts when you're walking. It sometimes can make you have what feels like a bowel obstruction, where you feel like you've got nausea and vomiting, and then you're moving just the right way, and then all of a sudden it relieves itself. The one down at the bottom that says cervical fibroid, that hurts with intercourse. That makes you feel like you have to pee all the time. That one bleeds for no apparent reason other than it just wants to bleed. You might have pain with that one. And then you have these ones that are kind of in the middle, the one that says submucosal fibroid. That one gets really big and can be a space-occupying lesion. So you feel like you're pregnant, or you look like you're pregnant, and I have some pictures when we move forward that feels like you have changed the way your clothes feel and the way that you carry yourself, because you're not pregnant, but that big mass is there. That one in the picture is small, but they can become very, very large. Let's see, so who gets them? Well, the data we keep using in OBGYN is that about 500,000, a little bit over 500,000 women a year get a hysterectomy. There's all different kinds of reasons. For cancer, for precancer, for fibroids, for endometriosis, but 40% are for the one reason, for fibroids. That's a lot of hysterectomies. And it's not the only thing we can do to treat them. Dr. Doan's going to talk about that. But a lot of them, of all the reasons people get hysterectomies, the majority are for fibroids. As high as 70 to 80% of women will get fibroids or be diagnosed with fibroids, or they're found incidentally by the age of 50. So it is something that's frustrating. It is something that people don't like, but it's so common. It's so common. What's interesting is that 90% of African Americans will have fibroids by 50. So if I survey the audience, a couple of you, one or two, are not going to have fibroids. This gentleman here is not going to have fibroids. This gentleman is hormonally responsive. So now it's starting to do it a little bit. Your ovaries are starting to do that whole cycle that I talked about, where it makes estrogen, and estrogen then secretes, or has a huge population. Then Brazil, right? People on the boat ride went, down to South America. So they have a huge population, as does the Caribbean. America is probably number 5. Before America, Germany. I don't know where that comes from. Germany. And I know, and Germany is very homogenous. There's not a lot of mixing of races in Germany. Another big place is Italy, but Italy has a lot of migration from Africa, so I think that explains that. And then South Korea. I know, so the number is Africa, then South Korea, Germany are right neck to neck, and then South America, then America, which I think is just, it just blows your mind. Yeah, South Korea and China. That was the other one. Okay. You can go forward. In America, who gets them? 30 per 1,000 women in African Americans, down to Hispanics, which are 11 in 1,000, and then white and Asian are 8 and 8. So 30 to 8 if we compare African American to Caucasian. Much, much more people that are black are going to have fibroids. And you know, there's a Dr. Marshall, who a lot of this data comes from. She's a very prominent African-American reproductive and infertility and OBGYN in University of Michigan, and she does a lot of work on fibroids, epigenetics, and things like that. And so she has a lot of data about who gets it and what they do. So a lot of this comes from her. You can go forward. Let's see. So I have a couple of little things. These are fibroids that we've actually removed, but I have some examples of what they feel like. So I told you that they're muscle growth, and they come in different ways. So this cherry one would be like a small one, and it feels almost exactly like this. That's a cherry, but this is what they feel like when we take them out. You see those little small ones? When those little small ones are in, you want to feel them? Wow. This avocado would be a calcified one. They're very hard. And you can appreciate that if that's by your bladder, that's going to hurt. This little rubber one, this one is one that's degenerating. This is what they feel like when they're degenerating. See how soft that is? That hurts really a whole lot before it gets to that point. And then those big ones, we see it off the top of the uterus sometimes, down low. Sometimes that big one, that rubber one, will be in the wrong place, and then a baby can't come out vaginally because it's blocking the canal. Does that make sense? So the cherry ones, those are the ones that are inside. Those are the ones that are inside the uterus a lot of times. Did you get a cherry? That are inside the uterus a lot. And we take these out with a little procedure that Laura's going to show you. So this is what they feel like on the inside. Like that. So there's ones at the top that are 8 to 10 centimeters, ones at the bottom. I imagine Terry had a lot like that, Dr. Jones. Go forward.
I noticed on your previous slide,
Yes,
you
ma'am.
didn't have any percentages for Native American women.
I noticed that too. American women. I'll have to find that out.
I noticed that too.
Yeah, can you give me your information and I'll
I'm
tell it?
Apache, and we consider it a spiritual ritual, when a woman cleanses, and then we relate it to dying.
Okay.
When my mother, they were in a concentration, not in, when they put them in the reservation, they were provided boxes with flour, sugar, everything that was not good for you. And so the women that knew, well, the ones that were, they went through hunger, they ate it, but that it changed it made us fat. And then we noticed changes in our, well, I wasn't born yet, but my, grandmother, yeah. So I wonder why he didn't have,
I will look that up, and then if I get your information, I'll send it to
Okay.
you. Dr. Jones can talk about how diet plays a role in our periods of fibroids as well. Yes, ma'am.
I don't want to jump the gun.
You're okay.
But knowing that I have both sides of the family with this, in the next generation, I have a niece who's already gone through the hysterectomy. I was just wondering, when are y'all gonna come out with the pill or the shot?
Dr. Jones working on it.
What's this?
Pill or the shot or some medication to keep it.
Some kind of ointment or something.
It might not be an organ.
That was a joke. It would be nice if it was.
So, with symptoms, like I said, about 40 to 50% of women may not have any symptoms at all. Those are a lot of those ones we find that are cherries, or maybe the tomato. We don't even know we have those until it really gets to the point where you're starting to have some symptoms, or sometimes they're not symptomatic at all. when we find them incidentally. They're definitely related to size and location, which we'll talk about here in a second. If they're in the muscle part, you just may notice that you need a little bit more ibuprofen during your period, and then that you tolerate it okay. You might notice that certain positions with intercourse make it more painful than others, but you don't really know why. Those may be fibroids in certain places or the wrong place. About 62% of women have more than one, which it makes sense. If one cell went a little rogue and made a fibroid, then it makes sense that another one probably would too. And then some of the symptoms are abnormal uterine bleeding, pain, infertility, recurrent pregnancy loss, and then bulk symptoms. You can go for it. So as far as abnormal uterine bleeding, so that's heavy bleeding, meaning you're passing lots of clots. You're bleeding through your tampon, through your pad. You're having to change them more than every 1 to 2 hours. Irregular bleeding, where you should be bleeding every 28 to 35 days, but now you're starting to bleed in the middle. Or now you're bleeding a little bit earlier than you're supposed to, and then it lasts longer, like maybe 10 to 14 days. Maybe one little thing or one little incident will make you bleed more, and you just don't know why it won't stop, like intercourse or exercise and things like that. If you look at those pictures, the first one on the left, you can see all the vessels. That would make sense that would bleed every time you move. That would make sense that's the one that's like the avocado. Do you see how hard that appears laparoscopically? It feels really, it's calcified, and it's kind of outgrown a lot of its blood supply, but still has a lot of vessels on the outside. Then on the right, there's a fibroid. Oh no, that's normal. I wanted to show you normal. That one at the top that says uterus, that's a normal uterus, just to go with some of the other pictures that you're going to see. And then if you look at the picture in the bottom, you can see that that one in the middle took up that entire space of that uterus, right? And then she has some on the outside too. You can go for it, Dr. Dillon. As far as pain, the one on the bottom, that is her entire uterus was one big fibroid, and she only had a little bit of normal uterus left. So I would appreciate that that would hurt a lot, don't you think? That looks like a full-term baby, full-term pregnancy. The MRI picture, her entire abdomen, you can see her spine. She's looking on from the side. This MRI is looking from the side like this. Her spine is there. Can you see it? And her entire abdomen is a fibroid. Do you see that? So that probably hurts, don't you think? Ibuprofen probably doesn't do very much for that. You're probably eating them like Skittles. And every time she moves or she sits down, she feels a sharp pain that maybe the part of the seat that's touching your butt right now, that's where that hurts. The part that's touching the seat. She can't tell you how to get there, but that hurts every time she moves. You can appreciate that she doesn't want to have intercourse, even though her husband's super cute. Right? That's not making her feel very sexy to have that there. You can go forward. Recurrent pregnancy loss is something that we see. The first picture is a completely normal inside of a uterus. What we do is we go in with a small camera. It looks like a pencil, and we go in and we blow it up with water, almost like a balloon, so that we can see. So that's with water descending that, and that's normal on the left. Do you see the fibroid in the second one? You can appreciate that with infertility, if a pregnancy continues to attach to that fibroid, it's not going to last. One, because it kind of outgrows its blood supply and it doesn't have enough nutrients. Two, because that actual endometrium doesn't have a lot of blood supply that it can recruit. Three, because there's extra proteins, prostaglandins and things like that, that make it have a middle in the back, that's also bowel. Can you appreciate that when we drop that uterus down, that keeps her from pooping? You see that fibroid? It's not that big of a deal. But that little orange ball can block that and make it hard for them to poop. It's okay. If it's also in the front, it's going to make it hard for you to pee. So what your bulk symptoms are going to be with urination is where you sit and you pee, and you get back up and you feel like, oh, I still got to go. And then you sit and you pee again because it can't get over the hump of the fibroid. It's in the way. Or that fibroid's there rubbing, and you feel like every time you go, or every time you walk, you feel like you got to pee. So you're running to the bathroom, and then you pee and there's not very much there. It's because of that irritation. That's what we call urgency. The other thing that we can't really quantify is kind of what Terri talked about, the effect on your lifestyle. It's something that Dr. Marshall and her buddies over at University of Michigan have done a lot of research on, but it's starting to grow and people are doing things like this and getting out the word because there's some things we can't really mark on our medical record. The effect on your lifestyle, the fact that you're missing work, you have notes, you're now anemic and you feel tired all the time, so you don't really want to go to your kid's soccer game or basketball game, that you're supposed to go on a trip with your husband and have all these like sexy clothes, and you don't really want to do that. Independent of whether you have pain with intercourse, you're not really interested because you feel pressure all the time and you really are not into it. That's something that we can't really quantify clinically. Also, there's limitations on how much you exercise, limitations on how it affects you just doing your everyday activities of living, like cooking for your family, or doing, if you are the person that does laundry, you don't really want to do those things. So that's something that you can't really quantify. Dr. Marshall did a study that said 100% of the people that she sampled, and it was I think 8 to 10,000 people that had fibroids over 8 years, all of them had symptoms of depression or anxiety, even for 6 months or less. 50% of them had feelings of helplessness, like, why did I have this? Terri, I'm sure I'm speaking exactly to what you were talking about earlier. And 1/3 of them had a negative body image, where they felt like their body had betrayed them, that they didn't do anything, they did what they were supposed to do. They're a fitness instructor, for God's sakes. And they still had something that they couldn't control. How do we diagnose? So, history and exam. You sound like your periods are not great, or you have bulk symptoms, or you're having a hard time getting pregnant, any of those things. And then we do an exam, and just like Dr. Doan had with Terri, you can feel the fibroids. You can see that there's something going on. The ones that are inside the uterus, you can't always feel those, but we can diagnose those with ultrasound. That's the gold standard. For GYN, ultrasound is our best friend. We can see most things with ultrasound. So I'll have some pictures of that. And an MRI is a good example. We notice a lot of times people come with a diagnosis of fibroids when they've had an MRI for something else. Like their spine was hurting, they have back pain, they get an MRI because they think it's their disc, and there's a big old fibroid there they never knew because they thought their period was normal. And then a CAT scan. Sometimes people have pain on their right, and they go to the ER, oh, it's got to be my appendix, I feel sick, I just can't poop. They get a CAT scan, their appendix is normal, but they got a big old fibroid. So that's how we diagnose it a lot of times. And then sometimes it's incidentally noted at surgery. Sometimes there's something there and we can't quite tell, and we see it laparoscopically. Sometimes we go in for something else and we see it open. Or when we go in and look for the causes of why you keep having miscarriages or why you're not getting pregnant, and we see it on hysteroscopy. I just have a couple of ultrasound pictures, and then we'll let Dr. Doan talk about how to treat. So the first picture on the left is an ultrasound. You can see this kind of whirly picture. I'll just point it out. This little whirly picture, this little whirl, that's the fibroid in the bottom. That's just a regular ultrasound. And one at the bottom is a 3D. And then what I loved about this one at the upper right corner is that it shows you the ultrasound image, and then it drew it out for a picture so that you can see where the fibroids are. So you can see there's two, and then there's one in the middle. But then it shows you that little lining there in the middle. Can you see that? And then you see that whirl right there at the bottom? So those are ultrasound images for the fibroids. Dr. Doan, you can go forward. And there's an MRI. You can see the MRI with and without contrast. So you see that big mass there, and you're going, what is that? And then on the right, you see the uterus is pushed in the back. The fibroid's in the front. Looks like she's pregnant. See that big circle? All right, Dr. Doan.
Thank you, Dr. Johnson. As you can see, when I asked her, what would you want the women in this room to know about you in addition to what's printed here? She said, first off, I'm a child of God. Amen. Amen. And that she loves to teach. So what you're getting here is a real gift today. Most doctors in that exam, that 5 minutes we get with them, don't have time to give us all this information. So thank you again, Terri, for bringing us together and giving us a forum to get this information. On your tables are brochures with information that you can take with you. So make sure to grab those, and there are extras sitting around. So when you go home and you're telling your girlfriends about what you heard, you can say, hey, take a look at this, and take it with you to the doctor. Because our goal is that we are healthier and we can have the kind of lifestyle that we are meant to have. So with that, I want to welcome Dr. Doan. She's going to tell us about, okay, what do we do now Because maybe there's some symptoms that you have. Maybe you've talked to your daughters, granddaughters, friends, and they're having symptoms, and we want to know what to do next. So with that, Dr. Doan, give her a round of applause.
Give me
You
some
know,
more.
he's supposed to be entertaining everybody, but everybody's like looking everywhere, but have their phones, you know. But as you heard, in the African American, it's 90%. And so it's an incredible problem in the United States. If left alone, most fibroids shrink after menopause, but that's not true of everyone. And the reason why it's not true of everyone is here in the United States, our BMI is increasing. And so if we have a BMI greater than 30, we produce estrogen also in our fat. And that fat will make our fibroids continue to grow. So you think, oh, let me get through menopause. And if you're Terri Allen and you get through menopause, you will not have a problem with fibroids because they will shrink. But if you're Laura Doan and you get through menopause, my fibroids might continue to grow. But in the United States, our fibroids are growing because we're overweight and we need to do something about that. So when is treatment needed? Well, again, most people don't need treatment. The fibroids will go away by themselves. But treatment is needed when you have abnormal bleeding. And I'm going to talk about abnormal bleeding a little bit more because most people, like, they talk to their parents or they talk to their mom, their grandma, and they find out, well, you know, I'm having this bleeding, I think it's abnormal, but I can talk to my parents or my mom. But their mom tells them, oh, I bleed way more than you do. Of course she does. She's your genetic person. She gave you those fibroids. And, you know, she's older and of course she's going to bleed more. But what you're doing isn't normal. And you need to know what normal is. So, unfortunately, we talk to our family. Our family is part of our problem. We inherited it. And we need to know what's abnormal, okay? And then pain. You shouldn't be having pain, okay? Your periods should not be that painful. And Tracy is African American. So she has probably pain. And not everybody I see in the office has pain, okay? We can help you. You shouldn't have pain, okay? And also we need to treat you if you're having infertility or recurrent miscarriages. If you're feeling bloated, you need to, there's no reason to feel bloated all month long. We can help, okay? And, or if you're having urinary frequency, you know, you need help. Okay, Tracy? Mm-hmm. Okay, so, what's abnormal bleeding? Okay, I thought that was really important that we know what abnormal bleeding is. So I brought wine. And, because it looks a lot like blood. You know, it's really true. I did this last night and I couldn't drink wine. But anyway, so Jesus turned water into wine, but I can't do that, so I have to use the wine. So a normal average cycle is 40, okay? So this is all you should be bleeding your whole cycle. Okay? Really? Well, this is what the average is. The whole cycle. This is what the average cycle is. That's what I mean. So you guys are asking. Extreme athletes. There's only one person I think in the room that's an extreme athlete. I mean, maybe y'all are. I mean, but I'm not. Maybe Tracy is, but okay. And smoking. Okay, smoking causes cancer. Smoking is really terrible for you, but smoking does decrease the size of your fibroids. Okay, don't do it. I mean, you know, well, because it causes less estrogen to circulate in you. But that's not a good thing. I mean, it is in some way, but, you know, it's still, you'll get lung cancer. I'd rather have fibroids. Okay, next one. Okay, now prescription medicine. There's something called tranexamic acid that works to slow down blood clots. So this does not change the size of the fibroids. It doesn't keep the fibroids from growing, but it does help with the bleeding. So you can ask your doctor for Lysteta if your only problem is heavy bleeding. This works. We use it on a lot of young people. Birth control pills, again, it's in your handout, but 75% of people improve the first year when we put them on birth control pills. This is one of the most common things we do, especially for young people. However, it doesn't decrease the size of your fibroids. As Tracy mentioned, estrogen and progesterone feed your fibroids, okay? And birth control pills have estrogen and progesterone in it. So the birth control pills might cause your fibroids to grow. The birth control pills work by thinning the lining of your uterus. They do inhibit new fibroid growth, but they don't keep you from growing your fibroids. And if they haven't worked after you've tried them 6 months, most people will call my office and they'll be like, oh, I need to try a new pill. But really, they just need to change what they're doing. You know, the birth control pills have to work. The Uterine, it's just like birth control pills. It has both estrogen and progesterone in it, and you put it in your vagina. And it is a contraceptive, but it also is, it thins up the lining of your uterus, just like birth control pills do. So these things usually do decrease the bleeding by thinning the lining, but the fibroids, if you have symptoms because they're big, it's not going to help that much. Okay. Okay, IUDs. So there's 2 forms of IUDs. There's the IUDs that don't have any hormones in them, called the copper or the Paragard. They don't help at all. They make things worse. They irritate the lining of your uterus and you bleed. Do not ask for a copper IUD. But the ones that contain levonorgestrone, the Mirena, the Liletta, the Styla, the Kalina, they do reduce. It's not. Again, it's a progesterone releasing hormone. But for some reason, these do reduce your fibroid volume, and so, and they keep new fibroids from working, or from producing, and so they're kind of one of our best options right now. So it doesn't make sense because they are progesterone, but it has been shown that they reduce your bleeding and reduce the fibroid volume. But if you have a fibroid that's sticking into your uterus, like Tracy was showing us, that has to be removed. Otherwise, you can just irritate it and bleeds and bleeds and bleeds. Okay. Okay, progesterone implants. So that's the next one on, the little rod that goes in your arm. And the injections are Depo-Provera, and norethindrone are the little pills that you take. So again, progesterone is a growth factor for fibroids, but it's been shown that the Depo-Provera actually does decrease the size of your fibroids. And Tracy was talking, like more progesterone actually decreases the size. And this is one of those examples. So, you know, this is something we use for contraception, but it does decrease the size of your fibroids. The other one's not so much. But they all work to decrease your bleeding by thinning the lining of your uterus. And they all stop new fibroid formation. Okay. Okay, so there's a new drug, mifepristone and ulipristal. They're progesterone receptor modulators, and so what they do is your uterus has receptors for progesterone, and when the progesterone goes to those receptors, your uterus grows. And progesterone is actually a bigger growth factor than estrogen, and so by these modulators, they block the receptor site so the progesterone can't work at your uterus, and so it makes those fibroids decrease in size and thins the lining, stops your bleeding. And unfortunately, in the United States, they're only available in higher doses, which cause abortions. They're given for abortion inductions, but in Europe and hopefully soon in the United States, they'll come at smaller doses so we can treat the fibroids. They cause a non-cancerous cystic change inside the lining of the uterus, so we can only use it in short bursts, like 3 to 6 months we give this medicine, and then they have like a 2-year period where the fibroids have decreased in size and usually don't cause heavy bleeding. But sometimes it doesn't work. I've tried it on somebody's relative here in the office and it didn't work, or in the room. Anyway, let's go to the next slide. I tried it at smaller doses, but she cut it up. Anyway, Lupron. Lupron is all in spaghetti, big meatball in spaghetti, and it's just covered by bowel. The bowel is the spaghetti. And so that's when you remove the uterus, it's not like you have a big void in your pelvis because you still have lots of bowel there, you know. Anyway, that's how I see it. But, so it's contraindicated if you have heavily calcified fibroids. If the fibroids can be resected with a hysteroscope, if they're hanging inside your uterus, if the fibroids are greater than 10 centimeters, if there's adenomyosis present. So what is adenomyosis? That's what I had, and that's why I had hysterectomy. Adenomyosis is when the glands that are normally inside your uterus grow into the lining of your uterus, and that makes you bleed heavier and have more pain. And so a lot of people have hysterectomies for that, or try many of the same things there. But this you can't do with adenomyosis. Strips and wash you off. Then I put a long skinny tube inside your uterus. I look inside your uterus, see if they have any fibroids that I can remove.